Hello, my name is Dr. Paul Richardson and I am the clinical program leader at the Jerome Lipper Multiple Myeloma Center and the director of clinical research there now at the Dana-Farber Cancer Institute in Boston. So at the meeting we have presented the results of the Panorama 1 study, which is a randomized double-blinded trial, placebo-controlled, incorporating bortezomib and dexamethasone with or without Panobinostat. This trial was performed in over 700 patients across over 200 centers and approximately 30 plus countries. The trial was designed to evaluate the progression-free survival between the 3-drug regimen and the 2-drug regimen. Other key endpoints included overall survival, quality of response, overall response, duration of response, time to progression, toxicity, and also quality of life. The study, in fact, demonstrated very nicely that for the 3-drug combination with bortezomib administered on a classical schedule and Panobinostat administered orally 3 times a week, 2 weeks on and 1 week off, that there was a clinically significant and meaningful progression-free survival advantage to the 3 drugs over the 2. This actually was approximately 4 months. The 3-drug combination generated a PFS of 12 months compared to approximately 8 months for the bortezomib and dex alone. Obviously, in that context, that's a very substantial median and generates obviously a range of responses and a range of clinical benefit that reflects that. Now, the important message is that in the context of response rates, the actual response rate was higher for the 3 drugs over the 2, but what was statistically significant and most striking was the higher complete response and near complete response rate compared to between the 2 arms. For the near CR and CR rate, this was approximately 28% for the 3 drugs, which is a very high value in a relapsed refractory population. And also, in comparison with the bortezomib and dex in the control arm, which was substantially less than that at around 15%. So there was a near doubling of the high quality responses seen. So in this trial, we were able to demonstrate an improvement in progression-free survival, an improvement in the quality of responses, as I mentioned, a near doubling of that effect. And also we saw clinically meaningful differences in not only time to progression, but also duration of response. Moreover, responses were rapid for the 3 drugs versus the 2, 1.5 months versus 2, and whilst this was not statistically significant necessarily, it did point to the activity of the regimen. Now, the side effect profile was challenging and is important to emphasize. The gastrointestinal side effects of Panobinostat, including diarrhea, were higher than the control arm, and also fatigue was an important side effect that was higher in the 3 drugs versus the 2. And finally, low platelet counts were another important side effect from the 3 versus the 2, and in a very, very small number of patients, some bleeding was seen. The key message, though, from the side effect profile is that generally speaking, these side effects proved manageable. And in that same context, with best supportive care and dose reduction, actually the duration of therapy between the 2 arms was actually very similar, pointing to the fact that the regimen has a manageable toxicity profile overall. Reflective of that as well is the relatively low rates of discontinuation of treatment. Having said that, I think as we go forward, there'll be important efforts to better refine the tolerability profile of Panobinostat. And finally, I think what's so important about this study is that it demonstrates that histone deacetylase inhibitors can be active in this setting. And most importantly, they open the door to further research with this broad class of compounds. And very excitingly, we have a number of newer drugs in this area coming through, including Reclinistat, which is also known as AC1215, which may have actually less in the way of side effects and hopefully similar activity, suggesting therefore we would have an even more efficacious platform in the future. For Panobinostat itself, one of the most important advances potentially will be testing it with subcutaneous bortezomib and also exploring it with other combinations. And hopefully we'll see some real excitement around those results in the next 6 months to a year or so. And one last comment is that the activity of Panobinostat was particularly striking in patients with higher risk disease, including patients with adverse cytogenetics. And therefore this offers the real hope that this class of drug, and Panobinostat in particular, may be able to be used to target high-risk cytogenetics and engender better outcomes in those patients.